Okay, so Eyal, you will go first.
Thank you, Ronit. I want to echo your words and say how good it is to see everybody here, and of course, can't wait to see you all in person very soon. Now, in 3 weeks, we'll talk a lot about what's expected in the summit in Los Angeles. Um, but I want to, of course, take the opportunity to first of all congratulate everybody, all the team, the FOH team, the research teams, on the work that they've been doing so far in getting us to where we are, and of course say hi to our new members. And there's a couple of them that are here with us today. So I haven't been following who logged on and who haven't, but let me just say a couple of organizations that are new for FOH coming on board. We have Mount Sinai, and I did see Nick Gavin here with us. Mount Sinai from New York. Welcome to FOH. We have Common Spirit that have just joined. There's a strong relationship with Common Spirit. Some of the people there already from previous years, but of course now we're happy to have them as formal members. Healthier Capital, another venture fund that is adding to the different stakeholders that represent FOH, and they'll be having a very important contribution, especially in Los Angeles. You'll hear more from Amir Dan Rubin. I'm sure many of you know Amir from his previous roles. He's joining us. Fairleigh Dickinson University, another important stakeholder in what we think would be the future of health and the role that they would play. And so Fairleigh Dickinson from New Jersey have joined us as well, and we'll see them hopefully today, but definitely in person in 3 weeks. We have Stanford come back. We've missed Stanford for about 2 or 3 years. They've made a return to FOH, so we're happy to have them on board, of course. Stanford Health. Sahlgrenska from Sweden, and the second hospital we have from Sweden, and Karolinska, of course, who's been with us for a couple of years with a new CEO, Christoph Pedroletti, will be joining us in Los Angeles as well. So just to give you a little bit of a flavor and to remind the newcomers what FOH is, I'll say very briefly that it's a think tank. It's a global think tank, a very unique one because of two factors, I would say. One is very, very broad in terms of international representation, represented by 14 countries in every continent, and you see many of them here, which means that we have to juggle between very different time zones, as you already noticed, which is always a challenge. Somebody needs to wake up in the middle of the night. It's typically Shelley. Sorry, Shelley. But we'll make it up to you at some point. We'll try to adjust your time zones.
No problem.
And so that's one of the advantages of having this very, very broad global perspective. And number two is having so many different stakeholders around the table. We thought that when we started FOH back in 2018, it's not just up to providers, and not even providers and payers set the vision of the future of health, but we all need to have a seat at the table. And so we have patient advocacy, and we have industry, and we have, of course, policymakers on top of academia and providers and payers. And they're all represented already in the names that I've mentioned from the newcomers, but also in the existing long-standing members as well. So I think that's also very, very unique. And this unique group is being facilitated through a very robust research project, because we've learned after the first year or two that it's not just enough to bring very good people into the room. If you don't have a very strong facilitation with people that know how to facilitate, we end up talking a lot but not making a lot of progress. And so we brought our two research organizations, research partners, to make sure we just don't just talk ourselves to death, but actually can drive some kind of agreements and conclusions, which then, of course, take shape in the articles that you're very familiar with. And so, first of all, I want to acknowledge Duke and the Center for Healthcare Policy, headed by Mark McClellan, which you all know, and Rob Sanders, and Rachel and Purva, all all here with us from the Duke Margolis Institute for Health Policy. And of course, we'll carry on their very important role during the summit 3 weeks from now, and you'll hear from them throughout this session today. And also our new research organization that many of you maybe have met for the first time in Cape Town when we were hosted by Discovery Health, and that's Statista. And we have Matthias here and Larissa and others that you're going to meet from the Statista team. We're adding another very, very important angle to mostly qualitative work, but bringing in some more data, surveys, and more research that they are providing to augment what we currently have going. And we think you're going to enjoy much of that, and you'll see some of it in action today. And finally, of course, to Talithia from FOH, our head of research for FOH, who's working with both Duke and Statista, synchronizing all this work together. So thank you, of course, Talithia, for your very important contribution. So I think we're very, very excited. First of all, I'm very excited. Our team, the FOH team, and I know the other teams, the Statista and Duke team, are all very excited for this session. We have a lot planned. We did a lot of preparations. This is, of course, leading towards the summit in 3 weeks, and we'll tell you more about what's expected. I know there's probably a lot of questions, but we'll make sure we take the best use of the time we have for the rest of the hour and a half for today. So thank you very much, and I'll turn it over to Chip for a few welcome words. Thank you.
Keep your on mute.
I just want to reinforce what Eyal said and thank everybody for being here. It's just amazing in some ways that our efforts have been sustainable since 2018, and each year I think we gain momentum and improve on the work we do, and just look forward to the future with all of you, and look forward to obviously our meeting in a few weeks. And beside the welcome to you, I just want to particularly thank all of our team, but Eyal and Oronit for their leadership and keeping the ball rolling here. So with that, I'll pass the baton back, but just really so happy to be with you all and really look forward to seeing you in LA.
So I think, Mark, this is your turn.
Great. Thanks, Oronit, and terrific to see all of you at literally all times of the day or night, representing just how diverse and broad this whole coalition has become. It's been a great partnership with Eyal, Chip, the teams on all sides to support your efforts in all of this. And I do want to give a special thanks to all of you, not just for being here today, tonight, morning, whatever time it is, but for all the participation over the past months in the expert work groups and the small meeting work groups, providing feedback along the way. The participation seems to be getting more enthusiastic and certainly more substantial. So we'll talk about that next. I also wanted to briefly introduce Purva Rawal, who's been an advisor for the Duke research team throughout this work. You'll be hearing from her today, seeing her at the summit. Purva came from us after some significant time in her career in strategy consulting for healthcare systems, and most recently as the chief strategy officer for the Innovation Center, the U.S. Centers for Medicare and Medicaid Services. A lot of background, highly relevant to this work. So bring to today, we're going to discuss some of our preliminary findings, considerations, including emerging recommendations and promising strategies to help organizations in FOH learn from each other about how to advance high-value primary care. There's some great examples from around the world on this, so plenty to discuss there around primary care, chronic disease management, and healthcare transformation to be more prevention oriented. We're also going to talk about leadership for change. That's been a really interesting exercise in identifying a whole range of characteristics that you all think are critical and frankly are still challenging to deliver on for managing through change. We have a lot of change management going on right now. I do think this is going to be an area that FOH may want to come back to, building on this year's framing, because this is a unique collaboration of leaders who are all showing the way to deal through change, and potentially a great way to add to the branding and the recognition of FOH. I'm looking forward to once again having a gathering in person that will be a strong learning experience for everyone, and that also will show how these ideas can successfully be scaled and built on around the world. So this is a practical, but also technically sound and evidence-based exercise, and we appreciate the partnership with Statista that's emerging to support that. And just a reminder, your work is leading to opportunities for global impact. We just got another New England Journal of Medicine Catalyst article accepted recently. Appreciate the collaboration on that and much more to come. So looking forward to today's discussion and then getting the most out of our time together in Los Angeles. So I think now we're going to dive in. So let me turn to Rob Saunders to kick off the discussions.
Thanks, Mark. And I'll give some just quick opening pieces here, and then we're going to jump into the content. So hopefully everyone has seen these slides before, and we provide those for the pre-read for today. And just one flag for this meeting, I think most folks know each other, but as you all noted, there are some new faces on the call. So encourage folks to say their name the first time they speak, so our new members are introduced. But if we go to this, so on this slide, the really goal for today here is a few things. One, we know the summit is coming up in a few weeks, and we want to make sure that you all have everything you need to be able to participate fully in that summit. And so this is an opportunity to share what the current research is, as well as other updates about the summit. It's also an opportunity for us to get feedback from you all on making sure any things that you notice in the research that would be helpful for us to make sure that we have in place before the summit. And we'll also use this as a chance to get some initial feedback from you all on which topics are of greatest interest to you as we're thinking about how things like the breakout groups and the like will be structured. So that's that goal for today. Maybe I'm going to turn to Talithia next to give a quick overview of what the research process has been like, and then we'll jump on into what we found. So Talithia.
Thanks, Rob. So it's hard to believe that we're already in October, but since early this year, the Future of Health research teams have been working really hard, Duke Margolis and Statista, to continuously inform our 2025 topics, leadership for change and strengthening primary care and chronic disease management. The year began with a comprehensive landscape review, mapping literature review and key performance indicators across health systems. That review helped us to identify the most pressing challenges and innovative strategies that are shaping the future of care delivery. We convened the expert work groups for both topics, and then we held 4 FOH virtual member discussions with many of you joining us to ground the research in real world experience and practical implementation issues. So that was both qualitative and quantitative analyses done by Statista as well as Duke. And then today is our pre-summit meeting, right? So this is the final step before we meet in person next month. And the goal is to ensure that every FOH member is familiar with the research and ready to engage in a meaningful and action-oriented discussion in Los Angeles. So before I hand it back to you, Rob, I do want to acknowledge and thank our fantastic co-chairs for both topics, Dr. Kevin Taub for Leadership for Change, and Susan Egman Leviton and Professor Lee Chen Earn for Strengthening Primary Care and chronic disease management. Their leadership has been outstanding and very instrumental in shaping the direction of our research to date. So with that, I'll turn it back over to you, Rob.
Great. And if we go to the next slide, so we included some executive summaries in your pre-read. I'm going to skip over those though and go straight to leadership. So as Mark mentioned and kicking off this topic, the leadership topic is different than some of the other work that we've done together as in Future of Health in the past. One of the things that we heard, especially from you all in the small group member meetings, is that there's been a lot that's been done on leadership in general. You know, there's whole textbooks, there's whole business school classes written on leadership. And you as members encouraged us to really push on, what's new, what's different, and where the future of health can make a big impact. And I think what we heard from you all was one of the challenges that folks are facing right now is that leadership for change looks different now, and especially will look different in 5 or 10 years than it did 10, 20, 30 years ago. And there's a set of competencies that healthcare leaders in the future will need, and that the future of health can play a really valuable role in outlining what those competencies will be and where leaders need to prepare, where leaders need to train their successors, to have in mind as they're thinking through their successors. And the future of health has such a powerful role to play here, given the global reach of its membership, given the long-standing history that all of you have in bringing innovations to bear and leveraging innovations and managing through changes. And so that's part of where the future of health membership really has a powerful voice in thinking about leadership. And it's really important, as we noted in this slide, there's just so many challenges that folks are facing nowadays. I don't need to read the whole slide to you, but during the small group member meetings, during those expert work groups, during the one-on-one calls that we had with folks, you all emphasize challenges you're seeing in the workforce, shortages, burnout, generational differences, some of the unsustainable financial circumstances that are facing healthcare systems around the globe. Everyone's having to do more with less. There's also challenges just keeping up with the really rapid pace of technology. Almost everyone noted that there were challenges with trust, whether that's with patients or with their workforce. There's new partnerships that you all are having to work through to advance population health, to advance underlying drivers of health, to really see therapies to go into practice. There's so many acute situations that have been happening, whether that's pandemics or cyber attacks or the like. And yet at the same time, there's a very limited leadership pipeline. There's a lot of turnover that's happening. There's a lot of short tenures from global CEOs. And all of this together makes leadership very different now and will make leadership different in the next 5, 10 years than it did, in the prior time. So wanted to just set the stage with those challenges. I'm going to turn to the next slide and our statistic colleagues who have augmented some of those qualitative findings with some quantitative work from surveys and the like. So I think, Matthias, you're turning to you.
Yes, thanks so much, Rob. So what we did is we conducted an exclusive survey among 100 hospital CEOs, as you can see here, which were mainly coming from mid-sized and smaller hospitals and different countries. We had 7 countries in the sample to understand how leaders actually approach change and transformation. And this is just a glimpse of the work that we have done. So the first striking insight that we see here is this big gap between urgency on the one hand side and speed of change on the other hand side. So 78% of the CEOs that we surveyed see a high need for transformation, but far less, only 37%, believe that their organizations can actually move fast enough. And this is, of course, an important question for leadership that arises from this. How to turn urgency into actual momentum, and which skills or tactics truly accelerate change. We will explore more of these insights at the summit, including country level and hospital specific perspectives, but this is the most striking insight that we have found so far from the survey. If we turn to the next page, to complement the survey, we in addition analyzed roughly 240 CVs of CEOs that lead institutions that are featured in the Statista and Newsweek World's Best Hospital ranking. And the goal was to understand who is leading these top-ranked institutions today and what kinds of expertise and training shape the leadership approach. So within the sample that we surveyed, medical backgrounds played a central role, as you can see on the left-hand side, especially in Asia and the Middle East. But the regional MD share also reflect the composition of the sample that we scanned itself. In North America, for example, many of the leading hospitals in our list are nonprofit academic medical centers, which are typically led by clinician CEOs, which contributes to a higher MD share there. Formal business education on the right-hand side, on the other hand, plays overall a rather smaller role. Only 1/3 roughly of the CEOs hold an MBA. But if you look at our sample, it is small, but in the APAC region, it stands out with a stronger business focus than the other regions we have taken a closer look at. So to summarize it very briefly at that stage, the difference, I think, show that leadership always exists within specific systems that are shaped by their structures and cultures, and there's no single unified model of what leadership currently looks like. And with that, I hand over to Larissa for the next insights.
Yes, building on that idea that leadership is shaped by the systems, we also looked at how these top CEOs reached their position. In this sample, we see that most top hospital CEOs are promoted from within, showing strong internal pipelines. But the pattern varies by region. So we see that Asia relies heavily on internal promotions, while Europe and North America more often recruit externally. These differences matter because they shape how new leaders are developed. So whether that be through long-term cultivation inside institutions or by building structures that can attract and empower leaders from outside. Moving to the next slide. Another key aspect of the leadership pipeline that we take a look at is the time in role. The shorter a leader stays in their role, the more qualified successors an organization will need. Across the global sample, we see that most top hospital CEOs currently have been in their role for 5 years or less, pointing to shorter leadership cycles and the overall industry trend of faster turnover that Rob also mentioned in the very beginning. As leadership cycles shorten, the pressure to continuously develop new leaders will increase. So this will be the case not just for top hospitals, but for all healthcare organizations that want to stay resilient in the future. With that, I will hand over back to Rob, who will walk us through how FOH can impact leadership for change.
Yeah, and I think building on the sort of the summary of those challenges, and then the quantitative work, which really highlights both the need for what we're doing, but also the heterogeneity and how leaders are being trained, where leaders are coming from, how to develop those competencies for the future. Really, the goal in the summit is to go deeper on some of these competencies and be able to be more specific on what specific competencies leaders in the future will need, as well as be able to bring in specific examples. And that's really one of the strengths that the FOH membership has been so great about, is being able to be specific about what this really looks like in practice and not just in theory. So if we jump to the next slide, we've heard it from all of you, a variety of actions that leaders in the future will need to take, and as well as competencies that leaders will need to develop in order to be able to take some of those actions. And we've got a long list on this slide. And if we jump to the next slide, just in the interest of time, we're going to go into 6 different areas at the summit, and starting off with a series of breakouts. So one of the areas that we're definitely going to make sure we do a deep dive in is how we're thinking through leveraging technology, leveraging AI in that change management process. This will be a cross-cutting use case for all of the breakouts that we'll have at the summit, but we'll definitely have one that is going to go deeply here because it's such an important topic. And we know many of you are thinking very deeply about how to implement technological change, recognizing it's not just the technology, there's also a major human element to all of this that you all have emphasized, and helping to get buy-in to seeing change happen. Another key breakout what we'll have here will be really thinking about that culture of innovation, that culture of strategic agility. Many of you have emphasized how important that is, but how tricky that is to build as leaders, to be able to build those cultures, and be able to support risk taking, to be able to have folks pursue bold visions. Several of you have also emphasized the importance of building trust and leveraging that emotional intelligence and being able to really, again, go deep on that human element of change management, which is pairs nicely with a lot of the technological change that you're seeing, is how to keep people bought in as all of this change is happening. If we jump to the next slide, we also have heard from all of you about changing communication, changing communications environment, whether that's how to manage social media, other types of new communications mechanisms, but also just how to build this sort of bilateral communications, given the challenges with trust and the challenges that folks are seeing with their workforce. Several of you emphasized you really wanted to go deeply on leadership succession, given that point that Larissa raised about internal promotions. Succession planning is really important for leaders, and several of you emphasized you wanted to think through what seamless transitions look like, what benchmarks you could have, and also thinking through training. That's a cross-cutting theme here of how do you train leaders to have these types of competencies. So that's a lot here. So if we go to the next slide, what we'd love to get out of you all now is really just getting feedback, any of these, resonate, not resonate. I think this bottom question is really one of the most important, which is what do you all want to get out of the summit? What do you want to leave the summit with? Because we want to make sure we are organizing and structuring the summit to have as much value to the FOH membership as possible. And if there's gaps or tensions in these themes, as we're putting this together, would love to think that through. So opening up to discussion now, and maybe to kick that off, Kevin, would love for you as the co-chairs help guide this work to help share, are there other framing issues, other things that you've been thinking about in this leadership topic?
Yeah, thanks. I think you've described it well, and I'm not going to start by answering those questions. I participated in all the sessions and had a hand in some of those slides, and I think you summarized it well. I'd just say a couple of things. I think it was a fascinating set of discussions around leadership. Maybe it's not a surprise that when you gather a group of leaders, CEOs and others, they're interested in talking about leadership. Sometimes talking about themselves and sometimes talking about the larger issue of leadership. I think, the advantage of that is that we as a group have as much domain expertise in leadership as anything else that we know. And that's fantastic. The disadvantage of that is that the discussions frequently, understandably, but frequently, I think, drift into anecdote and personal experience. And that's not a terrible thing, but I think it's a reality that we need to acknowledge as we sort of go through this set of discussions. Connected to that, I think, is the reality that the honest truth is that the reality of the science around leadership has been variable over the years. There's a lot of it out there, but quantity is not the same thing as good science. And all of it by nature is observational at best, anecdotal and sort of apocryphal at worst. And I think that the group has done a really good job, though, of attempting to walk that line and to take the multiple interviews that are out there with lots of different points of view and synthesize them into a small set of common agreed upon themes. And you saw that in the slides, and you'll see more of that. I think there are a couple of other interesting things that came out of this. A repeated theme is that these are unique and turbulent times. And I think a lot of people said, and that's very different than the past. My own personal view on that is these are certainly unique and challenging times that require a set of unique and maybe different competencies than we've had in the past. But I think it's also true that I've never met a generation that hasn't said our time is the most challenging and turbulent. I don't think we're unique in that. And I think we still have a lot to learn from previous generations of successful leaders. Um, I also think it was interesting that the Statista survey suggested that the need that CEOs have said the need for transformation is critical. That's a perfect example of, I bet there's not a CEO you would ask in the last 50 years that hasn't said the same thing. So true and not necessarily unique to this time. The only other word of caution that I would offer is that because of the nature of the science, particularly with this topic, uh, as we attempt to take a quantitative view, which we should, there's a real danger of, in this case, confusing correlation and causation. And I just want us to be on guard against that. So I'm going to stop there, and we should open it up for questions or
Thanks.
comments.
Thanks, Kevin. And I see we've already gotten a number of hands up, which is great. And again, speaks to Kevin's point that this is a topic that excites the FOH membership. I'm going to go with the order that I see on my screen. I'm hoping that's the order folks raised hands in. I think, Steve, I see you on the top left of my screen.
Yeah, so Mark and Robert, I'm sure it surprises you to have an opinion on this topic. Two things I'd say. First of all, congratulations on work really well done. I feel a little bit like we might be asking some of the wrong people. It'd be like me going to marriage counseling and telling the counselor exactly what my wife or partner should be doing, as opposed to listening to her. Last night I led a consumer electronics show piece in New York where there was a lot of concern about the leaders in healthcare. And one of the questions that was raised was, in a 10-year future, we get to a point where 40 or 50% of health system leaders don't come from healthcare. I mean, and I don't view it necessarily as a positive, especially in North America, that there are so many internal, where basically it's literally like Major League Baseball, where they say we have to have somebody who's been a manager, and they take all these folks in their past two jobs, were 24 and 82, but say, but at least he's been a manager. We do that a lot. I mean, very North American based. Healthcare is broken, fragmented, expensive, and inequitable, and a lot of it is our fault. So just taking the next person up might be a mistake. And then the only other thing I'd add, I think as part of this discussion, at least again in North American centric nonprofit world, the biggest problem is the boards. Boards by and large think anything different is a risk, while they're watching, their health systems lose $200 million and blaming everybody else, and then say, okay, well, this CEO didn't do it. Let's take the guy that was the CFO or COO who is also running it. So I think great work, great quantitation. I'd almost like to see a thing in FOH of what would be a radical shift, and how would patients and some other stakeholders view this that aren't just those of us saying, hey, this is what we think we should do.
Thanks, Steve. And appreciate your point on both thinking through how to get a broad base of feedback here, and also, as you know, if healthcare leaders of the future are coming from non-healthcare backgrounds, where are those trainings, approaches to get those competencies that are needed to make sure healthcare is able to manage in these different times?
It's going to be leadership and technology and taking care of people, right? I mean, I had 35,000 employees. I didn't need to be a doctor to do that.
Susan, I see you had your hand up.
Yeah, thank you. I'm going to just be very brief, but one of the things that I think is really important that I was glad to see on the slides today that I don't think I saw in the presentation that you sent out, but I may have missed it, is the critical importance, in my opinion, of training and providing resources for human-centered design and co-production of care for both of our topics, primary care and leadership, because I think that is one of the most important tools that we have to rebuild trust with our employees, with our patients, with our communities, to actually get things right. because we've got the right people at the table who actually understand what are the problems, what are the barriers to getting their work done. And I think it also really helps with workforce engagement. And I would love to see that much more prominent in what we're going to be talking about and how we can strengthen that. One last quick comment is that the CAPS Consortium just did our annual research meeting a few weeks ago, and the whole meeting focused on this. And I'll be able to share the resources, the videos, and the presentations with everyone shortly because that may be of interest. And it was an international group presenting.
Thanks, Susan, and would definitely want to see the resources that you find, and I think your point on human-centered design and making sure that we're engaging people in this work has been well shared by some other FOH members who have noted, as we're talking through a lot of these changes, the importance
Yeah.
of bringing folks along and engaging the teams and
And
solutions.
and actually redesigning the way that the work is done, I think is critical.
Thanks, Susan. And Sue, I really appreciate your jumping in here. And I think going along with Steve's point, it's really important to make sure we have a multi-stakeholder view as we're talking through leadership in healthcare.
Great, thank you. Good morning from the United States. When you were talking about leadership, just the word leadership, it sounds like the focus is on leadership of hospitals and specifically the leaders of hospitals. So the first thing that came to mind is if we pull back the lens a little bit and we're talking about leadership and improving, I think, patient outcomes. I think of other leaders in the ecosystem, one being patient leaders. And, at WHO, we created a framework on competencies of leaders. It was specific to patient safety, but it applies to this. And we created a competency framework for patient leaders of the world because healthcare is not going to change without the public demanding change. And so I'd like to just, as we talk about leaders of the future, I think we need to really think about the leaders in the patient world, community leaders, patient leaders, advocacy leaders, and I'm happy to share that framework with you. The other thing that I thought about when we talk about leadership, and we do, and we're talking a lot at Patients for Patient Safety US about leadership. What do patients expect of leaders? I mean, that may coincide with what healthcare leaders think of themselves, but I think it's really important to ask and survey patients about what are our expectations of healthcare system leadership. There might be some unique discoveries there if we really look at that.
I think so. And I think the goal of the work was not to limit it to just hospital leaders or hospital CEOs. I think, as with all work, there's a data challenge here, and it is sometimes easier to identify, let's say, some of our hospital leaders. But you're right, the healthcare of the future is going to need folks from all different parts of healthcare in order to see things come through. So please share the framework that you have,
Right.
and that'd be great to incorporate. Jeff, I saw your hand up.
Yeah, thank you. I wondered if during your discussions you considered the importance of building a leadership team. And that is to me, really critical for many of the topics that are discussed, communication and advancing how you think about technology and all these things. The importance of making sure you have a team that both will, speak up when they disagree with a leader, but also ones that can help communicate messages and things like that. So I wonder if that came up in the discussion and how that was addressed, because I think that's a really important part of leadership is developing, understanding who you need on your team, how selecting the right people for the team, whether that's coming from inside or outside. That team is really critical for leadership success.
And Jeff, that's a really good point, and you're right that has come up. And I know Kevin, you highlighted this as well. I mean, For instance, a hospital CEO doesn't necessarily have to know all the details of PCI or how to run an MRI scan, but needs to know what people on their team, do have those details. Maybe this might be a really good item as we're thinking for cross-cutting questions of what parts of this are we actually asking of that individual leader to take on versus making sure that they have the right type of team around them to be able to help with that. So yes, let's make sure we put that into the assignments for the breakout groups. I have Jan and then Shelley.
Hi, Rob. Just a quick one. Leadership has been studied for what, 50 years? And I do appreciate that you've asked all of us our opinion, but I would like to echo maybe Steve and also what Susan mentioned. Let's just check what's out there in terms of the top recommendations for what leadership is all about and start from there rather than just starting from what we all think leadership is all about, so that we build on best practice and take it forward from there.
And that's a good point, Jan. And I think we do want to make sure that we're not recreating the wheel. If there's particular recommendations that you've appreciated, especially that become more important, and for leaders of the future, would love to see those and make sure we're building on work that's already there. Shelley, I think we might give you the last word in this topic.
Thank you. And I'll be very brief as well. I think, so I was just about to say, I think although the evidence is perhaps by its nature not as necessarily as robust or repeatable as other forms of science, I think there is some literature, and it does go back about 50 or 60 years. And I just had a bit of a delve into it. And there are some notable changes over time, which I think might be helpful to us. So the kind of leadership strengths, that sort of heroic leadership style, as I might call it from England, of 40 years ago, is probably the very opposite to the co-creation, empowerment type literature now. So I think that tells us a lot about societal change and new generations. And then something about, and it is in the slides, I think, but one of our perhaps challenges is leadership outside of that box of an organization. So leadership in the community, but also leadership when it's uncomfortable because you don't have direct responsibility perhaps or accountability, but you need to influence over and advocate over and manage change over a whole system. So I think that systems thinking, systems leadership is probably one that most of us are facing and brings a new dimension to the thing where we used to have, kind of vertical system that perhaps had some easier things about it or different things.
Thanks, Shelley. And repeating back, I think, and you bring up a good point that some other folks have also raised, which is that many of the outcomes that leaders are being held responsible for now, like population health or underlying drivers of health, can't be done within one single vertical. And that requires collaborating versus competing. And it also requires working with folks that, as you say, you have no direct control over. But it's a different method of leadership than one where you have the ability to say direct command and control. And I appreciate your point on the notable changes over time. Would value anything that you want to share that we should make sure we highlight on those changes, especially as it points to where folks need to go in the future. So maybe for the next steps here, why don't we pull up the slides, and what we're going to ask is a quick exercise here from you all, which is we've raised 6 different topics that we're going to talk through at the summit, and would value if folks don't mind pulling out their phone, or we'll include the link in the chat. Inga just did that, to basically go on to Slido. So if you take your phone out and take a picture of that QR code, it will take you straight to a Slido page. And what we'll ask is that you select the 2 topics that you really would like to do deep dives on in the summit. This will help us to make sure that as we are trying to put together tables and breakout groups in the summit, that we have your thoughts in mind for where you would really like to push on. So you can either pull your phone out. If you are on your phone, if you click on that link that Inga sent, that will take you to a web page and be able to do it there and pick whether you want to really do deep dives on AI technology, that culture of innovation, strategic agility, trust, emotional intelligence, communication, leadership succession, training. And just to note that AI and technology discussion will probably be very cross-cutting across all of these leadership topics. Given that is a use case that I suspect all of you are having to think about. So we'll give a minute here just to let folks do that, and then we'll shift gears and talk about primary care. All right, probably got about half of folks have been able to do this so far. Okay, actually, I think this is everybody based off my read of the number of FOH members on this call. So let's take a to beat here. And we can also send out the QR code and link in case folks didn't get a chance to finish it in this call, and also make sure that folks who haven't had a chance to do it, who weren't able to join, go there. So with that, I'm going to turn things over to my colleague Purva Rewal. Purva's been taking a key leadership role, especially in our primary care work. So Purva, turning it over to you.
Thank you, Rob. And I also just want to say thanks to Mark and the rest of the FOH leadership. I've heard about FOH's work for several years, and I'm just excited and grateful to them for the chance to be working with you all. As Mark said, in my last role at the CMS Innovation Center, much of my work focused on testing payment and incentive models that support longitudinal and comprehensive primary care, which is kind of the perfect segue to the second research topic for discussion this year at the summit, which is on primary care and chronic disease management. And I think I definitely got the easier job today than Rob did, because this topic is maybe a little bit more typical of the issues that FOH has been leading on globally. Next slide. So the benefits of access to advanced primary care on population health outcomes and system costs are, of course, well documented, and that's not going to be new to anybody here. But despite that, we continue to face challenges globally for a number of reasons, and that's where we'll start, although most of the discussion today and at the summit will hopefully be focused on innovative solutions that might be able to be ready to be scaled or spread to other places. Talithia did a great job setting up the research protocol for this year. So we used the landscape review, the expert and small group member meetings that were conducted this summer. Thanks to many of you for participating. And then even individual member interviews to distill some of the key challenges facing primary care today across the globe. And just as importantly, to distill the opportunities for FOH to play a role in advancing solutions that, again, can be applied and scaled in different geographies. So the first, none of these, I'm going to move through these quickly because they're not going to be surprising to all of you, but it's helpful, I think, just to see them all in one place. You can kind of see how we're building the breakout sessions using these as the key challenges that emerged in the research. But first is workforce. Burnout, stress, and workforce shortages are near universal experiences for many of you. And at the same time that you have a more stressed primary care workforce, there's also a need to restructure primary care so that it is more team-based. Second is rising chronic disease burden. This means that the complexity of primary care is increasing, and the need to integrate and work with specialty care providers is rising. And that is reflected right in the name for this topic. And many of you as health system leaders are seeing this firsthand. As a result of the kind of increasing complexity, the rise in chronic disease, metabolic conditions, we see that payment models in many countries and regions are shifting to try to improve population health outcomes through value-based payment and care approaches. But this requires new and different partnerships and care delivery approaches to execute on. So another challenge. The next challenge is financial headwinds. This is across. I don't think there's a single topic in healthcare we can be talking about without discussing financial pressures and headwinds. Obviously, it came up in leadership as well, as Rob talked about. But in the context of primary care, rising costs often mean fewer resources at a time when primary care is actually needed more, and the complexity of what primary care providers and teams are doing is increasing. And then last, maybe we'll end on a more upbeat note, technology. This has the potential to improve primary care access and to support the workforce, but uptake is very variable from one country or region to the next and generally has been fairly low. So this is going to be a specific area of focus during all the primary care related summit breakouts, as you'll see. And I think it'll be a great point that we'll also be diving into in leadership, as Rob said, another cross-cutting theme. And so I think that will be a nice kind of through line over the course of the day. Next slide. So all of these challenges make this a timely and important topic for FOH. And as I said earlier, the research team has focused most of its time on finding solutions and case examples and gathering information from you on what the path forward in the future of primary care should look like, not so much just focus on the challenges. So we've organized the potential solutions to improve primary care into the 3 buckets that you see here, again, based on input from the FOH leaders, our co-chairs, Susan and Chen Ern, and most critically, findings from the research and landscape. So you see the breakout sessions and the discussion are going to be organized into these 3 categories: payment and incentive structures, workforce solutions, and multi-sectoral collaborations. The first is payment and incentive structures. So I'll just spend a second here. No, you can go back up, sorry. We'll be discussing strategies that address the tension between what's needed to deliver longitudinal, comprehensive, and continuous advanced primary care and the payment structures that are often inadequate to support that kind of care delivery. The second category will be primary care workforce solutions. So again, clinician burnout, lack of retention are growing challenges across the globe, and nearly all of you articulated that over the last several months of research. Some of the contributing factors include a strained workforce, mounting administrative burden, and lack of compensation. But several of you have already also cited very innovative programs and approaches that include leveraging technology to support team-based care and advanced primary care. We want to unearth many of those in the breakouts. And then the final category is multi-sectoral collaborations and integration. Again, advanced primary healthcare requires not just medical care, but the integration of other community-based services and sectors to support whole person care. And again, many of you have brought examples of that to the forefront that we'll want to dive into, and the ways to better connect health and social services to address behavioral health, social drivers of health, and other needs that we know impact health and outcomes. Next slide. Thank you. And then in this slide, in the next 2, I'll provide a more detailed preview of the small group discussions. Again, the research over the last few months, FOH member discussions inform the structure, but we're looking forward to your feedback. Each small group will discuss specific initiatives to improve primary care and chronic disease management across each of the 3 focus areas I just walked through. And as part of the discussions, I hope that we can also consider both the policy and operational or implementation issues that are going to be kind of part of each of these categories, as you know, during the breakout. So first, the payment and incentives breakouts are going to focus on identifying those payment and incentive structures that support longitudinal, comprehensive, and continuous advanced primary care. We're going to be using Discovery Health as a starting case example, which we heard more about yesterday from Dr. Whalen, who also shared some exciting study results from their work in South Africa. This is going to be an illustrative example, help us spark some discussion among the small group members. And then we'll be hoping that others can jump in and share more examples on payment incentive structures that are innovative. Again, we'll be thinking about those kind of policy and operational issues, thinking about generalizability and applicability to other regions as well as we walk through these discussions in person. Next slide. The workforce discussion is going to be focusing on, again, those implementation considerations. What are those policy obstacles and opportunities that global health systems can need to be examining when they're implementing approaches? We'll be taking a close look in this breakout, especially on AI and technology-based innovations that can support primary care to deliver better outcomes, to help with continuity of care, for instance, maintaining patient follow-up and decreasing workforce burnout. And then we also want to try to highlight or discuss some of the indicators of success here. How do we know if we're moving the needle on addressing workforce issues? So are we seeing efficiency gains? Are we seeing quality improvements? And are we actually able to measure workforce reductions or changes in workforce burnout or stress as a result of different interventions? Here we'll be using Costa Rica's basic integral health teams as a starting example. It's a comprehensive team-based approach to primary care with technology supports. And most importantly, they have some great and long-term outcomes data. So again, an illustrative example to kind of ground the discussion while we look to you all to share more of your experiences as well. Next slide. And then last is the breakout. We'll have two sets of breakouts focused on multi-sectoral collaborations and integration. So here again, we're going to want to talk about some of the key factors for that could facilitate implementation, including policy, maybe barriers and enablers that are able to support strong multi-sectoral collaborations. I think there's a role here for AI as well. We heard that from you all. How can AI and digital health tools in particular enable partnerships across different sectors? And then we also hopefully can touch on some of those metrics for success. So big picture, big dot outcomes such as like reductions in hospital readmissions when we have social services working more closely with healthcare providers, and then potentially improvements in socioeconomic health indicators as well. And here we're going to use South Central Foundation's NUCA model in Alaska as a starting case example. It's a really impressive comprehensive primary care program with integration across providers as its foundation. It too has some impressive outcomes that we can point to. And actually believe we heard a few weeks ago from, or maybe it was just last week, from Chen Erners, and that his colleagues from Singapore have also visited NUCA to learn more about their approach. And one of their sort of the secret sauce in the ingredient, or some of the secret sauce here is really their ability to collaborate with other providers and sectors in an area that is rural and resource strapped. Again, this is going to be an illustrative example that hopefully gets the discussion going. Next slide. So I think now we're going to pause, and I think we have maybe about 15 to 20 minutes before we to kind of get everybody's feedback. But before I open it up to all of the FOH members, I was first going to turn to our great co-chairs, Susan and Chen Earn, for their initial reactions. I see Susan first on my screen, so I don't know, Susan, if you want to start.
Okay, I'm going to be brief again, or try to be brief. I think this is excellent, and I think these models are all illustrating things that we should all be looking at in different ways that could be helpful. One of the issues that I am struggling with, and I've struggled with for a long time, and my colleagues in primary care policy do as well, and I have no idea how we will tackle this successfully, is I don't believe that the payment models in primary care can be budget neutral if we really want to fund primary care at the level that it needs to be funded. The differential between what primary care gets and with respect to hospitals, specialists, other players in the healthcare field is pretty striking and awful. And I just don't know how we're going to tackle that, but I do think that's an important thing that we should talk about. I'm thrilled with everything else that we have teed up, because I think it does touch on most of the challenges that we're facing right now. And at least in this country, given everything going on, I think everyone in primary care is pretty much frantic about what we're going to do to preserve the health of our population right now. But that may be unique to us, but I just think it magnifies the issues that we're seeing around the world.
Susan, thank you. I think that's a really good point on the, especially in the payment incentive discussion, to not just be focused on reducing costs when we're talking about primary care, but the percent spend on primary
Yes, the
care, because that really
percent
does
spend
vary. Yeah.
and where that, if we were going to raise that, where's it going to come from?
Right. Chandran, did you want to weigh in?
Yeah, just a few additional comments. I think great work by the team. First is I think as we talk about this topic of primary and chronic disease management, is the details are important. So it's not just having a clear idea of the strategy, because the contextual factors would influence how we adapt and adopt it for our respective jurisdictions. And in that context, the various streams that we have identified will not exist in a silo, because they actually interface with each other. And also, while some of the context may not be able to be changed so fast, we still need to make the changes accordingly. For example, the payment models. If to move from, let's say, a fee for service to a value-based system, that will take some time, but we can't say we wait until that happens before we make the change. So we have to creatively think through solutions, even amidst contextual factors which may not be that favorable. Secondly is, as we talk about team-based care, it is also important for us to then go into the details of who is part of the team, because we have traditionally been thinking of the team as healthcare professionals and those working in a healthcare system. But increasingly in primary care, primary healthcare, it is the people from other sectors with other skill sets, and the patients and their caregivers are also part of the team. So, and volunteers can be part of the team. So how do we actually bring across? So I think the NUCA is a good example of how we should do that. And to my final comment is that even as we talk about primary care and management of chronic diseases, we need to also see how can we bring our hospitals along, because in all systems, the most resources reside in our hospitals. So how can we, rather than having an either-or approach, where our hospitals and primary care seem to be competing, but how can they complement and actually augment each other? And in fact, I think WHO had a document quite a few years ago which spoke about hospitals augmenting the benefits of primary healthcare. So I think these are things that we need to think about it at the systems level, but also being able to cascade it down into the details to see how can we work in and make it work in our respective contexts. Thanks.
Thank you. And so I'm taking away a couple things. One, contextual factors. We're going to have to take those into account as part of our discussion. Anything that that comes out of the research, especially to make sure that we're thinking about applicability, generalizability of these case studies. And then on the team-based care, I think that would be a great discussion point to make sure we're weaving that into the small group discussion, not just team-based care, but who is part of the team, as you're saying, Chandran, and thinking about that more broadly. And then last, bringing the hospitals along, and that maybe that is some of the power of what FOH can add here, as a number of globally leading health systems are represented here, and you all championing sort of helping shape the future of primary care could be very powerful. So I'm just going to move down the line of the hands that I see. So Sue, I don't know if you want to start.
Thank you. Again, in thinking about primary care, I would really encourage us to, again, pull back the lens and look at the whole ecosystem that primary care operates in. And patients are a huge part of that ecosystem. So I was a little surprised not to see one of the solutions as more the empowering and engaging of the patient and community as a solution. An example of that is I live in what they call Frontier, Idaho. Frontier means that there's one doctor per 3,500 patients. And so that means, we have access problems. And so we heavily rely on the clinicians and the community members. We heavily rely on med tech and AI. And so when we don't have access to our primary care, if I want to see my primary care, it's at least 6 months out. So, my husband has 3 chronic diseases. He has remote monitoring, he has telehealth. We use AI all the time to help us determine, do we need to go to an ED, for example, because we can't get to our primary care. So I think there's a lot of solutions that we can talk about that engages the patient, family, and community, especially in primary care. We haven't fixed it for a long time. So as we try to fix primary care, we have to say, in the meantime, what are we going to do? And patients need to be more engaged, more empowered, as well as the primary care physicians, in bringing us into the mix for better outcomes, using medtech and apps and AI and things like that.
So I think that's a great call out for us to make that more explicit. I think we're trying to tap into that with the Discovery Health example. I think, Susan, you also said in the chat that had, repeatedly come up, but I think you're right. We can make that more explicit,
Yeah.
and it can be part of each of the breakout discussions. It sounds like you have some great examples on the AI medtech side that could add a lot to this discussion as well, but completely agree. Shelley, did you want to?
Yeah, just 3 very quick things. Just wanted to mention the most vulnerable people in all of our societies. We're seeing quite a big change in people not being able to afford GPs, not engaging with GPs or primary care at all. Homeless, drug, alcohol, and other drugs. Really, so that group that is very finds it very hard to engage with a typical health service, and often is lost to health services, including primary and community care. So that's the first thing. Second thing was our native populations. I'm really interested in the Alaska model. I don't know it, but we'll now look it up. We're paying quite a lot of attention to our First People in Australia, partly because their health outcomes are so terrible, about 36% worse across the board, and that's kind of adjusted. But actually, and I know this sounds a little bit, perhaps a little bit far-fetched, but actually looking at their approach to medicine and their First Nations approach to 65,000 years worth of medicine, and actually that worked in their communities, and perhaps learning from that, and I think that's very powerful. And then I just wanted to recommend a leader in this space called Professor Tom Wilkinson, who's a respiratory clinician from Southampton in the UK, who's been running chronic care programs for about 10 years now, linked with hospitals, but very much run in the community. And they're all nurse-led now. Nurse and AI and tech-led, but pretty amazing stuff, I think. So he might be a sort of thing that you want to include in the program as well. Thank you.
Thanks, Shelley. I'm glad that you mentioned sort of opening the aperture on when we're thinking about patient engagement, and making sure that we have a particular focus on those folks that are either having access to, or difficulty accessing services, or just difficult to connect with. And so I can see a payment angle, a workforce angle, a technology angle, and a collaboration angle, to making sure that we touch on the needs of those high need patients. And then we'd love maybe we'll connect with you on a connection to Professor Wilkinson as well, so that we can take a look at his work and be aware of his research. Ron?
Thanks very much, Priva. I think a good framing around this important discussion. I had 3 brief reflections, maybe building on some of the earlier points. The first one is, I think we probably need to double click on the different patient cohorts within primary care. And I'll tell you where I'm coming from. We've just done an analysis across our membership base. We found that 1% of our insured population accounts for 30% of our expenditure. And within that 1%, we're saying to ourselves, what's the specialist care? What's the primary care? It's a very complex population. but it needs your primary care across that population alongside specialist care. We then got a second cohort that's an at-risk population, typically diagnosed with chronic disease, and there it's both maintenance as well as prevention. And then we've got a big well population. So I'm just wondering, when we talk about primary care, there's a danger that each of us in the room has a different view of the typical patient population in primary care. So just encourage us to just be precise around our population definition for primary care. I think the second thing that we probably need to do some more research on is, where does primary care deliver return on investment versus specialist care? And I'll give you the background around this as well. Done quite an interesting analysis across our insured population. And in certain instances, specialists are more efficient in delivering outcomes than primary care physicians. Our traditional model is, well, the GP can do it at a lower cost, therefore I'm going to get a lower total cost of care. In fact, in some instances, it's better to send a patient to a specialist. From a pure economic perspective, the specialist gets to the heart of the problem, delivers lower long-term total cost of care. We don't have the answers to this, by the way, yet. We're digging further into the research around which patient populations are better suited to be led by primary care practitioners and which populations are better to be led by a specialist population. That's the second thought around refining our analysis. And then the final point, maybe a little bit to Sue's point. I genuinely think we can use artificial intelligence to make care more precise and personalized. It's not a question of just using AI for the sake of AI or telehealth for the sake of telehealth. The outcome should be precision and personalization in care. And those are two carefully chosen words. We can make care more precise, and we can make it more personalized with data and technology.
Thank you. I really like how you're forcing us to drill down a little bit in terms of specificity on who are the populations that we're talking about. Because if we're talking about case examples, interventions, innovative programs, you want to know who they're going to apply to and who they're not going to apply to. And then I think the other thing that jumped out at me is you talked about primary care delivering ROI versus specialty care. There's such complexity, medical complexity among patients, that it's really, I think, bringing those issues to the forefront, and we can try to cover that. And then last, I really like the idea of using precision and personalization as sort of goalposts and guides for what we want to get out of AI and technology in primary care and generally as well in healthcare. Sorry, go ahead.
Sorry, this is Tom again. I've been on blank in the background while I travel, so I apologize, but listening attentively. And so I can't see people's hands are raised, but mind if I just, jump on a quick point that was just made about this breakdown? I call it tertiary primary care, secondary primary care, and, all different ways of saying it. But I really think it's an important distinction. A lot of our research that we've done and performed are really usually occurring at academic medical centers, where there's mostly what I call tertiary primary care. We're managing multiple chronic illnesses, people in and out of the hospital. And sometimes that data gets, inappropriately discussed as if it was doing community-based primary care, where it's predominantly well patients, prevention, management of chronic illness. So it's interesting how that spectrum bias will drive, some of the literature unwittingly. So I just want to, as use the consulting phrase, and double click on that a little bit. So I know as a young primary care doctor at a major academic medical center in Manhattan, my first 3 patients had essential thrombocytosis and diabetes. I happened to have an office next to the world thought leader on essential thrombocytosis, and she was sending me anybody that had something other than essential thrombocytosis. So that is not normal primary care.
Thanks, Tom. In interest of time, we're all taking notes, so we're capturing your thoughts. But I'm just going to try to keep the conversation moving so we can give Orny time to kind of wrap us up. Alan, do you want to go next, and then Sue, and then we'll move to Slido. Did we lose Alan?
Alan, you're mute.
Yeah, sorry, I was gonna mention
Oh, there.
something similar to Ron's comments uh, regarding a need for understanding the relationship between primary and secondary care. And I'm not sure it's as simple as just handoffs. I do agree that there's a need for creation of pathways or trajectories for patients. And uh, in Canada, one of our jurisdictions, Alberta, developed something called strategic clinical networks, where they identified populations of patients with common needs, and then developed downstream teams from the primary care. So the primary care would get them in. So there's musculoskeletal, cardiovascular, cancer, etc. They worked exceptionally well. Uh, and continue to have benefits. Those teams could then, be sort of focus on value for those conditions. And clearly patients don't fall nicely into buckets always, but there are enough commonalities that it does create economies of scale for a significant population of patients. So I do think that trajectory concept where people are along a trajectory in their life and the services are wrapped around what they need. And I think just a second point I would like to make, because the primary care is going to be effective, if it can find that intersection with that specialty care as was described. But I do think that there is something in what Ron was talking about, which is not capable in most systems, which is the ability to perform those actuarial type analyses with high quality data, in which there's an incentive system both aligned with the health of the population and the financial well-being of the system. And most systems are not built the way Ron described that he's able to do with Discovery Health. Like, we don't have the quality of data at the level of the payer that could then drive that understanding and behavior. And so and it's not just the data. It's also the actuarial capabilities. It's also the incentive structure to drive people to the change behavior. So, and I know I don't know if that's really cooked into your bucket one, Purva, but it is something that it isn't just the incentive system; it's also the capabilities of the system to be able to do the work required to drive people to those goals. Anyway, those two thoughts.
Thanks, Ellen. And I think on your last point, I think we can sharpen that. That it's not you can put the incentive out there, but if the data aren't available or the capability is not there, you can't execute on it. So I think that's an important dimension. And then Sue, I think you'll get the last word before we go to
Yeah,
slides.
thank you. Just real quick, and I put this in the chat box. As we talk about chronic care management and primary care, you might take a look at the Paris survey that the OECD did. And they're having a webinars coming up like in the next, I can't remember, next couple of weeks, talking about how the Paris survey is really showing the outcomes of people with chronic diseases. And I think that this would be a great, and this may in the future be tied to payment and patient-reported outcomes and others. But I just wanted to put that it's in the chat, the link to the report.
Yeah, I'm familiar with it. I think that's a great call out. And especially something because it's an international survey, something that can create some benchmarks. So thank you. Okay, well, thank you to everybody for your feedback. If there's anything else you didn't get the chance to say, please either put it in chat or reach out to us. And now similar to the leadership topic, we want your input on which of the 3 topic areas you'd most like to engage in for small group discussion for this part of the closed research day at the summit. Take your phone, scan the QR code, or go to Slido and just enter the code you see there. I think it's the same as the previous one. And then once you're in, just select your top 2 topic preferences. So we'll give you a few minutes to submit your responses before I turn it over to Ornette. And just a reminder, we're going to have 2 tables per topic for these small group discussions.
Hey, Perv, I'm going to ask for your guidance. When you created these 3 buckets, which of these would integrate the topics that I brought up about patient engagement and, patient use of technology, and where would that fit?
You brought up some really great cross-cutting themes, Sue, but I would say on technology, probably the primary care workforce solution, because I think that has some specific AI and technology components there, and also multi-sectoral collaborations and integration. But I can honestly see you pulled out cross-cutting themes that could fit anywhere,
Thanks
really.
for guidance, yeah.
Mm-hmm. Yeah.
Is it just the one question?
Just the one question.
Yep.
Wow, I feel so complete. I did a task successfully on a plane. I'm so proud of myself.
And I think that may actually be everybody.
Yeah.
So maybe thanks, Purva. So maybe Ornette, turning to you to walk us through. Folks should finish if they were still working on it, but talk us through the summit.
Yeah, well, I'm the part of building the excitement for in the coming next few weeks. First of all, let me start with really thanks the Cedars-Sinai team, our generous hosting partner this year, Professor Shlomo Melmed, Dr. Jeff Golden, Morali Ganga Adharen. Really, they're doing great job for hosting the FOH this year. So really a big applause to them. I would like to show you that we built this year a very special mini site for the summit. So everything that you need to know before you go is actually on this mini site. And we are trying to keep green, so no more printing. Everything that you need, it's in the mini site. We shared it already. We will continue to share the link. So you have the high-level agenda over here. You can see also the dressing code. I would like to encourage you to go to the research day. So beside of the beautiful agenda that we put it here, as you can see from the beginning, from the morning, and we will start early this year, a little bit earlier than last year. But I also encourage you to go scroll all the way down to the, and look at the members that are going to participate this year. It's alphabetically. So just go ahead and see who is coming, even try to schedule a one-on-one meeting. This is a great time for collaborations and building new initiatives together. And also you can see the agenda for the open day, which is the leadership symposium. And you can also find your talking slot here, either in a panel or a TED Talk and so on. You will see that we are going to have a very interesting 3 keynote speakers. And also, I thank you if you have some questions and you don't feel that you have the answers, you can find it here, or you can always text me or Ruvan. I would like also to have a glimpse into the group activity that we are going to have on Wednesday. So this is a really interesting tour to the Huntington Gardens. And we have also created a beautiful spouses program to the winery and to the Getty Museum. So everything is on the website, and also we will share it through emails. Last thing that I would like to share, Eyal mentioned that we have new university, the FDU, the Fairleigh Dickinson University, for the first time, and they're doing really nice cocktail reception on Tuesday evening, actually Tuesday early evening. They would like to invite the entire FOH community. They're going to launch a new initiative, a name of Steve Klasko, about ambition initiative about humanics and technology. So you are all welcome. We will send you out the invitation. We have here on the call Colleen and Kent from FDU. So I will send the invitations, and please RSVP for this lovely cocktail reception as well. So we are really looking forward to see you all in less than 4 weeks. Any questions that you have, please don't hesitate to reach us. We are going to bombard you a little bit with more emails in terms of logistics and also research materials. So please pay attention to whatever we're sending out, and have a safe travel. Thank you all for being this morning, afternoon with the research team, and looking forward to see you very soon. Thank
Thank
you.
you.
Thank
Thank
you.
you.
Thanks.
Nice
Thank
seeing
you.
you all. Looking forward to seeing you soon. Bye.